10th of April. And in the New England Journal, we see this picture. It's a 48-year-old man who presented to ophthalmology clinic with a 1-week history of pain, double vision, and blurred vision in his left eye. And if we look at this, what we see here is a strange appearance of his iris, and the eye is reddened and looks like it might have been injured. We are offered several separations and normal eye findings. This eye is not normal. So what's separated? The pupil as a whole. It is either dilated or constricted. It can be regular or irregular. It can react to light or not, but I'm not aware that it can be separated. The structure that's involved here is the iris, so we would pick separation of the iris, and that's the correct answer. This condition usually comes to be through some sort of a blunt trauma to the eye. And if we look at the structures here, here is the iris in this section, and we can see it here. And somehow some tear has resulted from trauma. And here's another example here. The separation of the iris is from close to the outside of the structure. This condition is also known as iridodialysis. Only eye doctors know for sure, but that term is also used to describe this. Various things can happen to the pupil, which can be irregular through synechia or something of this nature. Pupils should react to mydriatic and cycloplegic agents. This is not a pupil problem. Now, the first topic in the New England Journal concerns deep vein thrombosis, and it concerns the strategy of compressive hose that are made out of a synthetic material that compress the calves in a rhythmic fashion depending upon how they're set. And these so-called compression solutions are supposed to protect people from developing deep venous thrombosis, which according to this advertisement kills 300,000 people in the United States each year. This idea was tested in a randomized controlled trial where patients at risk received this adjunctive intermittent pneumatic compression or not. And since these patients were at risk, they also all received some sort of heparin preparation, unfractionated heparin or low molecular weight heparin. Some patients also received clopidogrel or aspirin, but they were randomized to this compression treatment or no treatment. And the end point was pulmonary embolism, proximal lower limb deep venous thrombosis as detected by twice-weekly lower limb ultrasonography. What we see here is that 98% of the patients that were to receive intermittent pneumatic compression actually received this treatment, and a few in the control group also asked for this treatment and were given it, but the number was 10%. End result, if we look at this table here are the RR values, the risk factor quotients, and as we can see, nothing happened in this study. And if we look at this graph in terms of reaching the primary endpoint, the development of venous thrombosis in the calves as determined by ultrasonography, there was absolutely no difference in the pneumatic compression group compared to the control group. So it's a negative study. There were various secondary outcomes that involved safety and limb ischemia and serious adverse events that might happen with some sort of compression therapy. However, none were found. Now, these patients, as the authors admit, were also relatively healthy. So that might have been the cause for the fact that there were no differences in the percentages of patients who had skin injuries or other adverse effects. So we can conclude from this study that intermittent compression Seems to cause no harm, but there's no evidence that it helps patients that are anticoagulated anyway after some operative procedure or that are at some sort of a risk for venous thrombosis and thromboembolism. The next topic involves thyroid peroxidase, which is an enzyme that's expressed in the thyroid where it's secreted into the colloid. And patients can develop thyroid peroxidase antibodies that can occur in patients with Hashimoto's thyroiditis or in Graves' disease. And these antibodies are obviously detected by some sort of a test. Now, in patients that have abnormal thyroid function, it's usually relatively obvious what the underlying disturbance might be, but these tests are also done in patients that have no abnormal thyroid function, such as patients with pregnancy. And the idea in small trials has been that if patients that have these abnormal thyroid peroxidase antibodies receive thyroid hormone, that the number of miscarriages that they might develop would somehow be reduced. This is another example of treating some sort of laboratory values where there's no clinical substrate. So what these authors here is they randomly assigned 952 women to receive 50 micrograms of levothyroxine or placebo before conception and followed them throughout pregnancy. And the primary endpoint was live birth at least 34 weeks at 34 weeks gestation. Now, one of the things that occurred to me in my medical school years, we were taught to either replace thyroid hormone or not replace it, and 50 micrograms would not be enough. So I would imagine that what would happen here is that the thyroid gland would get a little lazier and TSH levels would drop, and it would make the thyroid gland would make less thyroid hormone, and that the patients would remain euthyroid. That's pretty much what happens, and nothing else did. So there's no evidence of giving asymptomatic women with antibodies against thyroid peroxidase that results in better pregnancy outcomes. And so there's no difference between placebo better or levothyroxine better. And in their discussion, the authors indeed mention that 50 micrograms of thyroid hormone wouldn't be enough anyway. And maybe if they would have given 150, the outcome might have been different, but I doubt it. The next topic in the New England Journal is the reversal of anti-factor Xa treatments. And this reversal can be achieved by giving andexanet alpha. And andexanet alpha is a recombinant modified version of human activated factor 10. This molecule actually acts as a bait for anti-10A treatment so that the actual factor 10A is no longer inhibited. Therefore, one could reverse the anticoagulant effects of modern oral anti-10A inhibitors, such as apixaban or rivaroxaban, which are commonly given in Germany, or also in terms of treatment with low molecular weight heparin. And in this huge study, large cohort studies, patients that received human factor 10A, this inactive form of human factor 10A called andexanet alpha, were evaluated in terms of their bleeding tendency, whether or not they developed any cerebral hemorrhage, whether or not these various anticoagulants were blocked through this treatment. And the results are presented here in the New England Journal. And what we can see here is the patients that received apixaban, these are box plots. So the value here is anti-factor 10A activity 150. And if bolus infusion of this bogus factor 10A drops this anti-factor Xa activity to almost zero, and there's a prolonged effect for a 12-hour time period. And if we look at patients that received rivaroxaban, again, the anti-factor Xa activity plummets to close to zero shortly after infusion, and this effect is sustained for a 12-hour period of time. And if we look at the patients that received enoxaparin, there's also a decrease in anti-factor Xa activity, implying that this material is effective against not only low molecular weight heparin, but also patients that receive oral anti-Xa agents, and that's shown here in terms of protection. Again, men, women responded similarly. The sites of gastrointestinal bleeding, intracranial bleeding, irrespective of age, and even with relatively low doses of adexanet alpha, this effect was sustained. And if we look at the timing of this treatment and any sort of thrombotic events, there were 34 patients that showed a thrombotic event during the 30-day follow-up period. That's a long period of time. These events might have occurred anyway. And there were 2 patients with infusion reactions, neither of which was severe. So if we look at these plots in terms of sensitivity and 1 minus specificity, hemostatic efficacy is shown. And in the patients with intracranial hemorrhage, the effect is visible, perhaps not to the same degree. So I think that acute major bleeding events that are associated with the use of factor Xa inhibitors can be treated with this strategy to reverse the effects of factor Xa associated agents, and major bleeding events can therefore possibly be ameliorated or avoided with good hemostatic efficacy at 12 hours as adjusted according to pre-specified criteria. The next topic at the New England Journal concerns the hypereosinophilic syndrome. And if the patients don't have some tropical eosinophilia, they could possibly have a clonal eosinophilia, an eosinophilic leukemia, if you will, perhaps related to a fusion gene that develops with this combination here involving the PDGF receptor alpha and this other molecule that results in basically a malignant disease. Now, these patients were excluded in this study, so these are not patients with leukemia or with tropical eosinophilia. These are patients with a hypereosinophilic syndrome of unknown origin. And the treatment for these options, for these patients, other than corticosteroids or agents of this nature, is limited. So what was done in this study is these patients were given an antibody against interleukin-5 receptor alpha, which is expressed on eosinophils. And this is not a common disease. I think this study was done at NIH. And indeed, eosinophil count in not all patients, but in at least 18 of them, dropped considerably compared to placebo. And after a period of time, the placebo patients also received this antibody against interleukin-5 receptor alpha. And when they did so, their eosinophil count dropped accordingly. So the baseline characteristics of these patients, whether or not they'd received glucocorticoids or interferon alpha or hydroxyurea or cyclophosphamide, other strategies to treat this fairly catastrophic illness is shown here, and their clinical involvement is also shown. And what we can see here is not in all patients, but in most, their condition improved with this treatment. And a patient example is shown here, improvement in skin lesions, and also improvement in other affected organs that involve these patients, including gastrointestinal tract and others. So we can conclude that, and also bone marrow examinations were done here, and we can see improvement with this treatment, indicating that this antibody against interleukin 5A receptor offers these kinds of patients an improved result compared to placebo. There was only one serious adverse event that occurred in this study. Somebody that received placebo got hypotensive. I'm not sure why, but otherwise the treatment was well tolerated. So in this small phase 2 trial involving diverse patients with PDGF receptor alpha negative hypereosinophilic syndrome who didn't have tropical eosinophilia, these patients seem to benefit from this antibody directed to IL-5A receptor and made them better. So we have something to offer patients with this unusual condition. Now, the review in the New England Journal that we were going to look at in a moment reminded me of Aldous Huxley's novel Brave New World, which was translated into German in the 1930s under the title of Welt wohin. And you might recall that in this Brave New World, society is markedly controlled by machines that are also capable of making decisions. And the patients are placated by drugs, which make them docile. And although there is no freedom in this society, everyone seems to be sublimely happy. And this was an important novel indicating what the future might be like. The world state is built upon the principles of Henry Ford's assembly line: mass production, homogeneity, predictability, and consumption of disposable consumer goods. Reach into your pocket to see if you have a smartphone. I'll bet you do. So this review is about machine learning in medicine. And we're even given a patient with this who was subjected to machine learning. This is a 49-year-old patient who notices a painless rash on his shoulder, but he doesn't go to the doctor. So months later, his wife notices this rash and sends him to the doctor, who diagnoses seborrheic keratosis, trivial condition. And later, while the patient undergoes a screening colonoscopy, apparently with no symptoms, the nurse notices a dark macule on this shoulder, and this lesion that had been diagnosed by the first doctor as a seborrheic keratosis is biopsied, and the biopsy is initially negative. But somebody else looks at the biopsy. Sorry, don't know what this is about. I have to get this going again. Übertragung läuft. Should be okay. So unless it stopped flickering. It says Übertragung läuft und Aufzeichnung läuft, so it seems to be running. So this is the patient. And so the patient is finally, after seeing 3 doctors and 1 nurse and colonoscopy and what have you, the patient is diagnosed as having an invasive melanoma. So he goes to an oncologist or a dermatologist that's familiar with oncology, and he gets systemic chemotherapy. Then the patient discusses this with one of his friends, who asks, "Why aren't you receiving a checkpoint inhibitor?" Could a machine make better decisions? And that's what this review is about. And the answer is maybe. Artificial intelligence is ideal for persons that have none of their own. And I admit that you can develop algorithms to teach computers to deal with various problems. And as they receive more and more data, they can refine these algorithms to make better decisions. So we have a conceptual task. And we have raw data from perhaps, hopefully, hundreds of thousands of patients that have malignant melanoma and how they come to a diagnosis. So these data are worked out by machines that develop a learning model, and then this learning model is refined so that the machine makes better and better predictions. I thought this example is pretty complicated, but what I envision is a machine that reviews medical records of patients in the hospital and evaluates elevated concentrations of serum creatinine and makes a decision whether or not a patient is at a risk for developing acute renal failure, which is associated with mortality in hospitals. And if there's input from thousands of patients and age and sex and diabetes, yes or no, or hypertension or whatever have you, computers could be taught to make a decision to warn the doctor that this patient is at a specific risk for developing acute renal failure. In terms of my specialty, this is how I would envision how this could be done. But these things are running. And then how complex is the prediction task? I would think a seborrheic keratosis is a lot more common than malignant melanoma. So I think this task is fairly complicated. And diagnosing malignant melanoma in the framework of a routine colonoscopy is also relatively uncommon. How are data from medical record systems to be entered, and how are they to be assessed by these machines that can then process these data? And how many examples have to exist to develop a training model so that the computer on its own makes better and better decisions? And how interpretable should these models be? So every patient is unique. That's true. We call that personalized medicine. Hippocrates suggested this 5,000 years ago, and we deal with treatment systems and large healthcare systems where tens of thousands of physicians treat hundreds of thousands to millions of patients. And we talk about clinical workflow. And of course, this whole process relies on electronic medical record systems. And if your institution doesn't have an electronic medical record system, you don't even have to worry about artificial intelligence. Then expanding the availability of clinical expertise. And again, the problem of garbage in, garbage out, high quality data are required here. So then this discussant goes over this patient again. And again, this is the vignette to which we were introduced that ends with a physician friend asks the patient why he's not receiving immunotherapy. And this is what the computer might have done. It goes like this. The 49-year-old patient takes a picture of his rash with his cell phone. And he sends this to a dermatologist who immediately gives him an appointment for a dermatology visit. His insurance company receives this information again through an app and immediately approves his appointment for the dermatologist so that this is automatically paid for. The appointment is automatically cross-checked with the patient's personal calendar to make sure that he has time on that day and doesn't have an appointment at the hairdresser or at a dentist instead. The dermatologist makes a biopsy of the lesion, and of course the pathologist that reviews this makes no mistakes at all. And I suppose the patient, and immediately the patient is diagnosed as having the the melanoma, which is then excised by the dermatologist. And presumably he gets the checkpoint treatment instead of conventional chemotherapy. So that's classical machine learning, supervised and unsupervised, and that's what this review is about. Another vignette in the New England Journal involves sepsis syndrome, which is fairly complicated and now handled in emergency departments by guidelines. And the idea is that physicians in patients that have a high risk of sepsis make a decision within 3 hours and treat these patients with so-called bundled therapy. So who has sepsis syndrome? Fever, not always. Sometimes the patients have a low body temperature. Shortness of breath, oliguria, mental status changes, diarrhea, nausea, vomiting, tachycardia, hypotension, shock. These are all suggestive findings in sepsis syndrome. So the sepsis guidelines nowadays give us 3 hours to make this decision, before the bundled treatment is then given, which consists of 30 milliliters of crystalloid per kilogram of body weight if the patient has hypotension and a lactate level higher than 4 millimoles per liter, vasopressors, etc., and the acquisition of blood cultures and broad-based antibiotic therapy is the recommendation. Now, people are considering that this decision should be made in 1 hour rather than 3 hours, which almost precludes sending the patient to CT or doing any other diagnostics. So this example is given to physicians, and then we are asked, what are the options? And what will the hospital administrators say about increased costs or reduced costs from these ideas? And so the readership of the New England Journal was confronted with option 1, adopt a 1-hour goal for sepsis bundle, or option 2, maintain the 3-hour goal for sepsis bundle. And I made my decision, and then I checked to see what the other doctors that read the New England Journal had to say about it. And what we see here is the doctors are split 50-50. So I'll let you know how this comes out. There's another patient from the New England Journal that can't breathe out of the right side of his nose. A biopsy was done, and this is a fungal infection. Sporangia in various stages of maturation. I guess I don't want that. So the patient had this condition largely operatively removed, and it occurs in Africa and South America, and now you know what it looks like. The next topic at the New England Journal that bothered me a little bit is dysmetria. Now, neurologists know all about dysmetria, but basically it's a movement disorder in which the patient loses track of where he is through time and cannot perform repetitive movements or find things like the finger nose test, and etc. Now, dysmetria is not normal and should be pursued, although I think sometimes it's difficult to elicit dysmetria. So here's our patient. 13-year-old girl claims she has migraine headaches. At 13, I guess that's possible. And they wake her up in the middle of the night. She's had 2 episodes of early morning nausea and emesis, and she goes to the doctor, and he doesn't find anything except mild dysmetria of the right arm. 13-year-old. What do? Observe with a headache diary, obtain a CT, urgent lumbar puncture, a brain MRI, topiramate for headache prophylaxis. I give up. But dysmetria is not normal. And if you really find dysmetria, if there's a difference comparing one side to the other and the test is repetitively abnormal, then I think this warrants probably imaging. And in this case, we would prefer MRI because we're looking for what we're possibly looking for is probably subtle. So that's what the neuroimaging people say. They don't really say what she had, but if she has a lesion occupying the posterior fossa space, then we would like to find it. Excuse me. Now we move to the Lancet. And the information that you have to know before you can interpret this next study is an earlier paper that was published in the Journal of the American Society of Nephrology in 2009. Now, what we're interested in as studies is treatments that make the course of chronic renal disease protracted so that the people either avoid dialysis altogether or have a longer period of time that they're free from dialysis. And one of the thoughts has been to give patients sodium bicarbonate because patients with chronic renal disease commonly have a problem with excreting ammonia and develop metabolic acidosis. And in the early part of chronic renal disease, the metabolic acidosis is not associated with an increase in anion gap since it strictly involves the ability to excrete ammonia. So a study was done, a relatively small study in patients with chronic renal disease that were randomized to sodium bicarbonate, baking soda, cost nothing, or control, and the patients were followed for almost 3 years. And as we see, or 2 years. And as we see here, giving the patients bicarbonate actually raised their serum bicarbonate levels from the low 20s here to about 24 millimoles per liter, which would be normal. So with this treatment, you can substitute for the inability to excrete ammonium and provide the patients with normal acid-base balance. And if we look at the amount of sodium that was excreted, it goes up a little bit, but not very much. Sodium bicarbonate does not have an influence on blood pressure, and there was no change in blood pressure in this trial. And proteinuria was also examined. It was not affected. But the change in glomerular filtration rate over time was actually less in the patients that got bicarbonate compared to the patients that received placebo, which was highly suggestive, but the study's small and has perhaps other aspects that make it less convincing. So much larger studies are running to see if this really would ameliorate the course of chronic renal disease. Now I introduce you to viveramir. Viveramir is a neutral polyamine, and you swallow it, and in the stomach it accepts hydrogen ion, so it becomes protonated once ingested and exhibits selectivity for the chloride ion. So it works in the stomach, and so it removes hydrochloric acid from the stomach. And if hydrochloric acid is removed from the stomach, more bicarbonate remains, and it would increase the serum bicarbonate and treat metabolic acidosis. Now, sodium bicarbonate costs nothing, but it could cause belching, which some patients might find objectionable, although the nutritional status in this old Jason study was improved by the patients given sodium bicarbonate. But viveramir is now marketed under the name Tritsida, and even Goldman Sachs, JP Morgan, and Cowen and Company have invested in the company making viveramir. So this is the first study on viveramir. This is not an endpoint study. This study in the Lancet was merely performed to see if in patients with chronic renal failure, viveramir would increase serum bicarbonate and would be tolerated. So this is a phase 3 trial with no endpoints and no hard endpoints. And the endpoint here was whether or not viveramir would effectively and safely correct metabolic acidosis. So here are our patients, and there are large numbers of patients, relatively large numbers of patients here that received viveramir 124 compared to placebo, and they're chronic renal disease patients recruited from basically all over the world. And chronic renal disease patients have hypertension, which 97% of these patients did, and they're commonly diabetic, which 2/3 of the patients were, and they have a whole variety of other disturbances that you can appreciate here, but the distribution was such that both groups are similar. And to your great relief, you will find out that viveramir increased serum bicarbonate. And here we see that, and it increased serum bicarbonate about 4 millimoles per liter compared to placebo. And the patients that the increase here is dependent upon what the value was. In some patients, it was up to 7 millimoles per liter. Presumably, these are the patients that had the most severe metabolic acidosis, but it seemed to increase bicarbonate in this entire spectrum of patients with chronic renal disease. And so in terms, and the effects were seen in men and women, and they were seen in Europe and the United States, and they were seen in Black people and white people, and they were seen even in patients receiving baseline alkali therapy, and they were seen in various degrees of patients with metabolic acidosis, and also in patients with severe renal failure compared to not so severe renal failure. And their physical function seemed to be improved, but the improvement was also observed in the patient in the earlier bicarbonate study that I showed you. So they had the patients stand up, and the group that had viveramir seemed to feel better since they had a longer chair stand time. I'm not familiar with this test, but I'm relieved that it was done. So it looks like Vivaramir is going to be no worse than sodium bicarbonate in the terms of treating this problem, and I hope Goldman Sachs comes out ahead. The next study, excuse me, the next study involves the treatment of malaria, and the question is, pregnant women that get malaria have major problems, and we would like to protect pregnant women from developing malaria during treatment. So we're interested in an intermittent preventative treatment during pregnancy. And so this is a study that compares two regimens, sulfadoxine pyrimethamine versus an artemisinin-based regimen with piperacillin. So it's basically, is SP better or worse than DP? So that was tested in these pregnant ladies in Africa, and the randomization seemed to work pretty well in terms of these various variables shown here were not different. And adverse birth outcomes and these sorts of things, it looks like DP is better than SP. And that was also shown here, because if we look at parasite prevalence, it drops quickly with more quickly compared looking at the artemisinin-based regimen, which I would expect would be the case, compared to this older regimen with no artemisinin. So it looks like DP beat SP. And in terms of adverse events, trying to figure out exactly what happened here. But I think that the added value of the study is that the DP regimen versus the SP regimen detected a difference in birth outcomes, and also included the assessment of QT prolongation in the women that you can inspect in this study. The next study I found rather interesting. This was not a randomized trial. This is a prospective cohort study in patients, in French patients who were treated with specific chronic hepatitis C virus treatment compared to patients that didn't receive this treatment. So this is a prospective study in adult patients with chronic hepatitis C infection in 32 hepatology centers in France. And the investigators included patients with hepatitis B, and they also included patients with decompensated cirrhosis or cancer, and patients that had undergone liver transplantation. And the co-primary study outcomes were incidence of all-cause mortality, hepatocellular cancer, and decompensated cirrhosis. I would sincerely hope that the direct-acting antivirals would beat not doing this thing, using older treatments or not doing anything. So this is how this study was conducted. And the authors point out that no prospective study has examined the benefits and harms of direct-acting viral drugs. And so this study was observational, and decisions about treatment combinations, treatment timing, and screening were made by the clinicians involved. I was rather surprised that the study was done with the advent of these antiviral drugs that seem so effective. But you can look at this table, and it looks like the antiviral drugs win hands down because they reduce all-cause mortality, they reduce liver cancer, they seem to reduce decompensated cirrhosis, and look like a good idea. I sincerely hope these investigators have considered treating their control group or untreated group with these drugs so that these patients can also accrue the benefit. Then this very complicated study involving 37,298 women with breast cancer that were investigated in 26 randomized trials. So this is a meta-analysis, and the question asked here is dose intensity of chemotherapy as determined by more frequent administration or sequential scheduling. one might imagine that more frequent administration would be better than sequential scheduling because the patients would receive a more comprehensive and intensive chemotherapy. And that was the question that was asked here. And indeed, it looks like the dose-dense schedule beats the standard schedule over a 10-year period of time. And these results also are statistically significant, but the results are underwhelming, since death without recurrence wasn't affected, but all-cause mortality was affected, and that result is also statistically significant. So if you deal with patients with breast cancer, you should know this information so that you can make a decision about the frequency and intensity of their care. So it looks like dose intense is better than the standard treatment. Now, from the BMJ, I picked out this paper to show you because this is another evaluation of the so-called PURE study. And we've looked at a half a dozen of these already, but this involves estimations of sodium and potassium intake as determined by literally hundreds of thousands of spot urines to correlate that with cardiovascular events. The study was performed in 18 high, not very many, middle, quite a few, and many low-income countries sampled from urban and rural communities. And we've seen these tables before. Now, these data are expressed as sodium excretion in terms of grams per day that were extrapolated by means of a formula. You'll recall that 1 gram of sodium is 44 millimoles of sodium, so that a sodium excretion of 3 grams a day would be about what the average intake is in Western, so-called Western societies. And also Eastern societies, as long as they're relatively modern and have a McDonald's around the corner. So if we look at the disposition here, in terms of excretion per day, we see that the hazard ratio of cardiovascular events, again, are lowest in the patients that are about in the middle. And major cardiovascular events here. And the idea in this study was the effect of potassium excretion on the risk of sodium excretion, and in which ranges this effect is more likely to occur. And what we see here is that the effects of potassium were most prominent in the patients that are sort of in the middle range of sodium excretion. And that was also evaluated here, where if you eat a lot of potassium, it seems to help the patients the most that are in this middle range of sodium excretion rather than the patients that are at the extremes. So in terms of your being concerned about what you're eating, you can consider this amount of information because what the study adds, according to the authors, is the WHO simultaneous targets of low sodium intake, what impact they might have in terms of high potassium intake. And a low sodium intake with a high potassium intake was consumed by a very low proportion of these massive populations. And the combination of moderate sodium intake, 3 to 5 grams per day, which is sort of the mean value of what people eat in Germany and the United States, with higher potassium intake was associated with the lowest risk of mortality and cardiovascular events. The phenomenon showed here again is a so-called J-shaped association study, a J-shaped association of sodium intake with mortality and cardiovascular events. And some friends of mine that are terribly interested in this issue were very pleased, and that it seems to follow the range of salt intake in the United States and China and in other societies that's shown here, and the risk of cardiovascular events. So they got a little letter published in the Lancet, and they were so ecstatic that I thought that I would show it to you. Now, the review in the Lancet concerns Leonardo Da Vinci, and his last name was not Da Vinci. He was from Vinci, which is a smaller city, a smaller town in Italy. So his name really means Leonardo from Vinci. He is the most broadly talented person from the Renaissance. And you're all aware of all of the wonderful things that he did. He also painted some lovely pictures of some young ladies. I know you all know about the Mona Lisa, but Leda and the Swan, here is my favorite. I won't tell you why. I found out, looking at Wikipedia, that poor Leonardo was also accused of sodomy, which is unfortunate. Had he done this today in Brunei, he would have been sentenced to death. And I'm surprised the Pope let him get away with it, but that's probably why he escaped to France, where he eventually died. Now, what Leonardo did, amongst many other brilliant things, was study anatomy. And he was specifically interested in the brain. And it won't surprise you that this article is by neurologists. And Leonardo did a pretty good job on the brain. Here's some of his sketches. There are some additions here, I admit. He was pretty good on the skull, and his anatomical accuracy is amazing. He was interested in the intraventricular system and also made casts of the intraventricular system of the brain, and made wonderful drawings of it that are remarkable in their accuracy. I was surprised that if Leonardo was so great on the brain, why was he so bad on the heart? And I think he probably knew how the heart works, but he was probably afraid of the Pope, and for that reason didn't describe how the heart works, which then had to wait for William Harvey another 75 years later to inform us about how that works. Now, the case in the Lancet is a disease I've never heard of, dysplasia epiphysealis hemimelica. It's not even a genetic disease, but it's a disease of altered cartilage growth that doesn't seem to have a genetic preponderance, and it occurs once in a million people. So there are probably 4 people in Berlin that have this problem. And in this little report, these investigators described the problem in this 18-year-old man. This young child, when he was a child, they didn't recommend hip replacement. That's how this condition looks on X-ray. And this wonderful computer model shows that the cartilage development here was probably abnormal. So this is not hip dysplasia. This is not arthritis. This is this condition, dysplasia epiphysealis hemimelica. But I wanted to draw your attention to this because some of our listeners drew my attention to it. What is this story again about platypnea related to orthodeoxia that I talked about 1 week ago? This is a condition where the people are short of breath sitting up and have a right to left shunt. And if you lay them down, their blood gases improve. So I looked at the first description of this that I could find in the literature, and this little report was published in 1976 when I was chief resident at Indiana University Hospital, where I first read about this, and Jimmy Carter was president. He was the president that told the American people, "I will never lie to you." And he never did, and that's probably why I only got 1 term. There are 3 patients described here. 2 of them have hepatic cirrhosis. And the 3rd patient has a congenital atriovenous fistula, but also probably could have fistulas elsewhere. And if we look at, and this is 1976, these are arterial blood gases. They're expressed in torr, but it's the same as millimeters of mercury. And this first patient, while lying down, has a PO2 of 60, and while sitting up has a PO2 of 44. If you give her 100% oxygen, she's no longer hypoxemic, but the same phenomenon is seen. This phenomenon suggests that she shunts more sitting up than lying down. And the next patient shows this pattern also, and the 3rd patient also. And the authors discuss this. They point out the fact that shunting of blood through the lungs can occur with massive severe lung disease, pulmonary fibrosis in the end stage or whatever have you. But in this condition, where the patients get better lying down compared to sitting up, that they called orthodeoxia and platypnea, this is a shunt phenomenon. This is an anatomic shunt phenomenon, And the examples that these patients had were 2 patients with cirrhosis and another patient that had intrapulmonary anatomic shunts. That's it for this week. Thank you for your attention. Want to hear this story in German? Stick around. Oh, God.